Okay, students, now we're going to start talking about the care of a client with reproductive disorder. Next slide. So we start off with the overview of the anatomy and physiology of the male system, and you have taken anatomy and physiology. Make sure that you refer back to these chapters to really understand the parts that are involved in the male reproductive system. Of course, you know that the testicles are really, really important. Those are internal the structures that house or holds the sperm. This is where it takes place here. You have your ductal system, epididymis, vas deferens, and ejaculatory duct and urethra. And then you have other accessory organs such as the prostate gland. And remember, the prostate gland that is can have cancer, and we want to make sure that we assess the BPH for BPH and definitely a PSA. The urethra and the penis are, and then of course the sperm. All right, the testes should be hanging outside, so to make sure that the young man or male has good fertility chances. Next slide. This is a cross-sectional view of the male pelvic showing the location of the male reproductive organs. Next slide. The male sex cells, greatly enlarged here, and then the female sex cells surrounded by the sperm at the time of fertilization. So fertilization is the union of the male, the sperm and the egg. This process will be discussed even further in your maternity class. Next slide. Of course, now you have your female reproductive organs. Here we're talking about the ovaries, the fallopian tubes, uterus, vagina, external genitalia, accessory organs, peritoneum, and mammary glands. And these are all of these play a very important role. We talk about what happens with menses, the tubes, and sometimes individuals can get pregnant. Fertilization can take place in the fallopian tubes, and when that happens, we end up with something called ectopic pregnancy, so forth. Next slide. So this is a cross-sectional view of the female pelvic showing the location of the female reproductive organs. Next slide. Here is a sectional view of the uterus showing the relationship to the ovaries and the vagina. So clearly the fallopian tubes, so the follicle is released and then it goes into the tubes, and the tube, and then it's supposed to move down to the endometrius, to the uterus, to implant there if pregnancy is going to take place, or shedding if there's no pregnancy that's going to take place. Next slide. So this is a lateral view of the breast. Breast, you can see the fat lobules, the ampules, the ducts, the nipples, and it's an accessory organ, and it plays a very important role in pregnancy and nutrition for baby. Next slide. This is a slide showing you the mammillary ovaries, showing successive stages of ovarian, follicle, and ovum development. The process that takes place every single month. We have to ovulate. Women ovulate every 28 days, and the process of the follicle being released, and then travel, and then of course the hormone levels that go up. Follicle stimulate the follicle, luteinizing hormone, estrogen, and progesterone. Those levels are high, especially progesterone, because they go high in an attempt to protect the pregnancy, because a high level of progesterone will stop abortion. So if there's a sperm to fertilize that egg, then the progesterone level and the estrogen level will remain high. If there's no sperm to fertilize, then there's a drop, and when that drop happens, that's when you see the shedding of the endometrius. Next slide. This figure is showing you the lymphatic nodes of the axillary and also the lymphatic drainage system. So clearly you can see the lymph nodes. If there's a problem with the with the breast cancer or other non-cancerous conditions, the lymph nodes will be enlarged and palpable. And in terms of the lymphatic system, the drainage, so metastasis can travel and cause other problems with that as well. Next slide. Human sexuality, it's a sense of being feminine or masculine, right? And there are a lot of influences on our sexual health. So overall wellness, which includes sexual health and sexuality, it should be part of our healthcare program for our client. Illness and sexuality, illness can cause changes in the patient's self-concept and result in an inability to function sexually, such as diabetes, such as drugs that are used for blood pressure monitoring and steroids. Next slide. There are some assessment of the reproductive system, but prior to doing objective assessment, you want to make sure we collect data subjectively. So we want to know about the patient's history of childbirth, history of any sexually transmitted disease. You want to find it about their social history, sexual preference, find it about their nutritional habits, family history, and genetic risk that they may have as pertain to the different conditions that may come about with the system. You want to find it about the current health problems that they have. Are they having pain, bleeding, discharge, or masses? And then you could start with doing a physical exam, which would, you want to assess the breast. You want to assess the abdomen and any examination of the genitalia. And we will do pelvic examination. You do a biomanual exam where you're palpating to feel for the internal organs. You palpating for the prostate gland, and in men 40 years and old and above, you palpating for the testicles for testicular cancer. And then of course you're going to examine the external genitalia for lesions, for dryness, examine the inguinal hernia, examine the scrotum and the prostate, and then of course there are other diagnostic tests that we would do that are more imaging. So there's quite a few on our list here. You can see colposcopy, laparoscopy, pap smear. It's usually done, and it's a screening measure, so it's secondary prevention in trying to identify early on any signs and symptoms of signs of uterine cancer. You have biopsy, especially if you suspect patient complain of any lumps or pain. So we want to assess the breast, and if we suspect a mammogram is done, and mammogram is usually encouraged for people that are 40 years of age or older or sooner, if they've had family history of cancer, and the history is usually looking at maternal side. So we can do biopsy of the breast, cervix, or endometrium. There's colonization, there's dilation and correct, so like for DNC, for removal of unwanted pregnancy or ectopic pregnancy. We do cultures and smears, to assess for sexually transmitted diseases. We do, iodine test. This is what happens is a dye is injected in the mucosa, the cervix area, and usually what happens is a normal mucosa would pick up the stain, but a mucosa that has cancer, it doesn't do so. So it's going to help differentiate and diagnose cancer. There's histogram, there's Rubin's test, which would tell us if the tubular insuffocation, to tell you if the fallopian tubes are occluded, because sometimes someone who has pelvic compartmentary diseases from repetitive cases of sexually transmitted disease, the tube can be scarred. So this test is going to help us. HCG, that is definitely used. The human chorionic gonadotropin is used to assess for pregnancy. So we talk about that. Serum CA-125, that would help us assess for cancer. Many tests. So make sure you go over each of these tests and understand the nursing implication or indication or intervention for these guys. Next slide. All right, testicular biopsy, semen, analysis if we're thinking that someone may be infertile, prostate smear, rectal exam, and of course prostate-specific antigen to assess for prostate cancer. Next slide. All right, Monarch, this is the beginning of menses. It follows the breast development, usually in about 2 to 2.5 years. The average age range between 9 and 17. The cycle ranges for about 24 to 28 days, 32 days. The average is 28 days. The average flow is about 3 to 5 days. The average flow is 35 mLs per cycle, and this is why some flow is a little heavier than that, and so that's why we monitor for anemia in a woman who has menstruation. Next slide. Amenorrhea, starting with the conditions. Amenorrhea is an absence or suppression of menstrual cycle. The most common reason for amenorrhea is usually pregnancy. The complaint is I have no menstrual flow, and usually at least 3 months to diagnose. The medical management is we need to find out what the cause is. If it's pregnancy, then we know that they will remain amenorrheic until pregnancy ends. And sometimes we'll use, depending on the cause, hormone replacement therapy will be used. Next slide. Dysmenorrhea is uterine pain with menstruation, so painful menstruation. And usually there is breast tenderness, headache, abdominal distension, nausea, vomiting, vertigo, palpitation, excessive perspiration, colicky pain in the back. And it can be very debilitating, especially for young children, adolescents. Next slide. So management includes exercise and nutritious food that is high in fiber. Heat usually would help. Mild analgesics, prostaglandin inhibitors definitely helps. Blood pressure, birth control pills can also help normalize that. Next slide. Menorrhagia is excessive bleeding during regular menstrual flow. A lot of times the causes for this will be endocrine disorders, inflammatory disturbances, or tumor, right? Tumor, cancer. So that's when you see a heavy menstrual cycle, we want to be concerned about uterine cancer. And menorrhagia is uterine bleeding between regular menstrual cycles, okay, after menopause, right? So it may indicate cancer or benign tumor of the uterus as well. Next slide. All right, so PMS. PMS is premenstrual syndrome. Is believed to be related to neuroendocrine events that occur in the anterior pituitary, usually seen before your periods, like 3 to 4 days prior, and cysts when it stops when the menstrual cycle comes. So these very moody, and so if you're in a classroom full of a lot of ladies, this is what you see, because everybody tends to go into PMS about the same time. So there's irritability, there's lethargy, there's fatigue, there's sleep disturbance, depression, headache, backache, breast tenderness, vertigo, abdominal distension, and acne. Next slide. So pharmacological management, analgesics, diuretics, because they tend to feel bloated, prostaglandin, diet that is recommended is sodium that's high in complex carbs, moderate in protein, low in refined sugar, and limit caffeine, chocolate, and alcohol. Reduction or eliminating smoking has been proven to also help, and exercise, adequate rest, and relaxation. Next slide. Menopause. Menopause is the normal decline of ovarian function resulting from the aging process, right? It may be induced by radiation of shrinking of the ovaries, or surgical removal of both the ovaries, right? Not considered complete until 1 year, right? So you're not menopausal until you stop having your menses for 1 year. Next slide. What are the clinical manifestations? There's decrease in frequency, the amount and duration of the normal flow, shrinkage in the valvular structure, shortening of the vagina, dryness of the vaginal wall. So we have to keep this in mind. Loss of skin turgor and elasticity, and increased subacute fat, decreased tissue breast, and osteoporosis. They are at risk right now. Next slide. So the issue was they're losing their hormones, so we want to replace it. So there's hormone replacement therapy, estrogen, Premarin, and Provera, calcium supplements. It is controversial because replacing the therapy has been known to cause other problems, cancer and heart disease. Next slide. All right, male climacteric is a gradual decrease of the testosterone levels and the seminal fluid production in men, usually 55 to 70 years of age. Clinical manifestation shows decreased erection, decreased seminal fluid, enlarged prostate gland, decreased muscle tone, and loss of hair or thinning of hair. Medical management is usually emotional support and treating impotency with drugs such as Viagra. Next slide. Erectile dysfunction, it is inability of an adult man to achieve penile erection. There's different types, functional, anatomical, atonic. Nonetheless, it turns out to be the same. So the medical management and nursing intervention requires removal of the cause if it's possible. Treat the disease, Viagra, or sometimes mechanical devices, penile prostheses. Next slide. Infertility is inability to conceive after 1 year of trying of sexual intercourse without birth control and trying. Infertility can be caused by other things such as pelvic inflammatory disease, mumps, back in the days, or undistended testicles, because if your testicles are in the abdomen for the male, there's no sperm, right? So they will be infertile. Medical management and intervention depend on the cause. Hormone therapy to repair any occlusion. If the testes are in the abdomen, we can try to bring it down. Intrauterine insemination, in vitro fertilization can also be used to manage the condition. Next slide. So now we're talking about the different infection of the female reproductive tract. Simple vaginitis, common vaginal infection usually caused by E. coli, streptococcus, trichomonas, candidiasis. So there are some it's inflammation of the vagina, and the discharge is based on the causative agent, so yellow, whitish, grayish, or curd-like discharge, and that shows you that it's candidiasis. It's usually painful, burning and itchiness, especially with candidiasis. Next slide. If in fact the patient is having malodorous, copious amount of vaginal secretion, douching is encouraged. Usually douching is not encouraged because it changes to normal flora. We can use vaginal suppository ointments and creams to treat the specific organism. So for example, if it's candidiasis, we use nystatin, so the antifungal drugs. Sitz bath can help, and usually encouraging the patient to be abstinent from sex during the treatment. Treating the partner if it's necessary for trichomonas, so those that are sexually transmitted. Next slide. Cervicitis is an inflammation of the cervix. Sexually transmitted diseases can cause that. Clinical manifestation is backache, whitish exudate, menstrual irregularity, and so to treat it, we can use vaginal suppository depending on what's causing it, right? If it's or antibiotic therapy. Next slide. PID is a pelvic inflammatory disease. Again, this can be caused, most of the causative agent are gonorrhea, staphylococcus, that causes an acute, subacute, recurrent, or chronic infection of the cervix, uterus, fallopian tube, and ovaries that has extended to the connective tissue. High risk procedures usually put them at risk, so individuals with surgical examination procedure, sexual intercourse, especially with multiple partner, can put them at risk to have PID. Next slide. So what is the clinical manifestation? Fever and chills and severe abdominal pain, malaise, nausea and vomiting. They may have mild odors, purulent vaginal exudate. And so one of the reasons why we want to treat, these sexually transmitted disease because of this complication, right? But not only does this complication becomes an issue, but it also scars the tissue, the tube. So which would, relate to or cause infertility. Management includes antibiotic, analgesics, and bed rest to try to eradicate the causative agent. Next slide. Toxic shock syndrome is an acute bacterial infection that is caused by Staphylococcus aureus, usually occur in women who are menstruating and using tampons, but toxic shock can be from other things that is left behind. So there are other things people can put that will cause this type of condition. All right, but tampon use, especially in the back in the days, was a major cause for this. Next slide. Clinical manifestation usually occurs between 2 to 4 days of the menstrual period. There's flu-like symptoms, sore throat, headache, red macular, papular, or diffuse rash. There will be decrease in urine output because the kidneys can shut down. So we're going to look at the labs that suggest that we urine and creatinine, pulmonary edema. So the key is to identify and treat, and IV antibiotic therapy is usually needed. Next slide. Endometriosis. It is endometrial tissue that's usually where it should be in the endometrium, but it appears outside of that, so outside the uterus. This tissue responds to normal stimulation of the ovaries, so it bleeds each month. So bleeding is a problem here. Clinical manifestation, lower abdominal pain and pelvic pain, and it may radiate to the lower back, the legs, and the groin. The management includes anti-ovulatory medications, so to stop them from ovulating, pregnancy, laparoscopy, sometimes total hysterectomy is the treatment option. Next slide. This picture is showing you the common site of endometriosis. So of course the uterus area and outside of that. Next slide. Vaginal fistula is an abnormal opening between the vagina and other organ, and what you see is the urine and the feces being expelled from the vagina. So abnormal opening, right? So if you have the intestines open into the vagina, then you're going to see things that are not usually there. So these guys are really high risk for high infection. So that's why we give them oral or parenteral antibiotics, high protein, increased vitamin C, and of course we need to repair the fistula, right? Or try to divert the urinary or fecal entry. Next slide. These are the different types of fistula that might develop in the vagina and the uterus, right? So the abnormal opening of things into where they should not be. Next slide. Displacement of the uterus may be another thing where the uterus is displaced, right? It's supposed to be up there. If you remember the picture that we showed you, how the view of the ovaries, the fallopian tube, and the uterus, and then the vagina. So it's displaced. This could be caused by congenital or childbirth. So individuals who have multiple kids put them at risk where the uterus would displace. It could displace backward, retroversion, or retroflexion. Next slide. So what are some of the clinical manifestations? That your uterus is displaced: back pain, muscle strain, leukorrhea, discharge, and heaviness in the pelvic area, right? Because it feels like it's dropping. Literally, it could drop. I have seen a uterus that's dropped. So what is the management is, because it's displaced, we want to put it up and push it up and hold it up. And so The pessamer are devices that are used for management, and then of course suspension of the uterine. Next slide. You have uterine pull-ups of the uterus through the pelvic floor and vagina opening, right? So there's going to be fullness in the vagina area, back pain, the bowel and bladder problems, and protrusion. You actually will see the cervix and the vaginal wall in the peritoneal area. So yes. Next slide. So this is a picture that shows you the uterus, how it pull up. See how it's literally in the vagina, indeed. There's different ways it could displace or fall out. Next slide. So again, management would be surgery, right? Remove it completely or just put a device to hold it up, the pessamer. All right, next slide. You have cystocele and rectocele, another displacement, but this time the cystocele is displacement of the bladder into the vagina, or rectocele, the rectum moves towards the posterior vaginal wall. Next slide. So it's showing you A is cystocele, the first diagram. You see how the bladder is bulging there, and B, the rectum bulges down there. Next slide. So cystocele and rectocele clinical manifestation. For cystocele, remember it's bladder, right? So you see signs and symptoms that point to that: urinary urgency, frequency, and incontinence and pelvic pressure. Rectocele, constipation, rectal pressure, and hemorrhoid. So surgical repair is what we would do, or suspending bladder suspension. Next slide. Leiomyomas, these are fibroids of the uterus, benign tumor, arise from the muscle tissue of the uterus and is stimulated by the hormone, ovarian hormones. Clinical manifestation, usually they complain of pressure, pain, dysmenorrhea, menorrhagia, constipation. The medical management is they can try to control it. Sometimes it gets better after pregnancy or with age, but if it doesn't, myomectomy or hysterectomy will be the treatment option. Next slide. So these are the different types of where they could tell you the different tumors. They are benign tumors, not cancerous, but they can cause debilitating, problems, excessive bleeding that would require to be removed. Next slide. Ovarian cysts are benign tumor that arise from the dermoid cells of the ovary. Generally, they may not be any symptoms, but if they are, they get big. They can have pain. So they could be palpable with the examination, disturbance in menstrual cycle, pelvic heaviness, and pain. So again, if it bothers them, if it doesn't bother them, they'll leave it alone, but they can do ovarian cystectomy. Okay, so they can remove the cyst. Next slide. Cervix, cancer of the cervix, squamous cell carcinoma. Usually, we do a pap smear to identify if someone has abnormal cells. If they are, we can start ahead of time. So that's why it's really important to do your pap smear, because it's a secondary prevention to screen so that we can find it early before it invades the other organs, the vagina, the pelvic wall, bladder, rectum, and regional lymph nodes. Individuals at risk are those who are sexually active, clearly, multiple sex partners, multiple birth, and chronic cervical infection. Sexual partners because of HPV. So HPV, there's different types of HPV. We have over 100 types of HPV. Most of them are asymptomatic, but the two that are really high risk for cervical cancer are the 16 and 18, right? So this is why we give the vaccination to individuals, because we don't want people to end up with HPV and or cervical cancer. Next slide. So what are the clinical manifestation? Again, few symptoms early in the stage: leukorrhea, irregular bleeding, spotting, and in advanced stages, there's back pain, there's upper thigh, and leg pain. Next slide. So what's the management? Well, it depends, how soon they found it, if it's in suit, where it's, that location, so they can remove it. Early on, they can do hysterectomy. In advanced stage, they can do radical hysterectomy and pelvic lymph node dissection. All right, because if it's advanced stage, it's spread, so they're going to be radical. So they're going to remove the ovaries, the uterus, the fallopian tube, and then also try to go for the lymph nodes. Next slide. All right, so cancer of the endometrium, adenocarcinoma of the uterus, clinical manifestation is usually bleeding. Unusual bleeding, 50% will have cases. Usually 50% of them will have, those who bleed after menopause will have cancer. Abdominal pressure and pelvic fullness. What do we do for someone who has endometriosis because it's in the uterus? We can do total abdominal hysterectomy with bilateral oophorectomy, so they're removing both of the ovaries and as well as the fallopian tube. There's radiation, there's chemotherapy because there's a vagina, so the chemotherapy, the radiation can be put right in the vaginal cavity, so to hold it. So that would put you at a position where we make sure we log well in the patient. You don't want the radioactive agent to drop and fall into percussion when it comes to radiation treatment in the hospital. Making sure that individuals that are pregnant don't go in, children, and the distance between the radioactive individuals and the people that are caring for them. All right, next slide. Cancer of the ovary is the fourth most common cause of cancer death in women, and the reason why is because a lot of times when you suspect that you have it, the cancer is already metastasized. So those at risk for ovarian cancer are individuals that are infertile, those who do not ovulate, nulliparous, habitual aborter, high-fat diet, exposure to industrial chemicals. So having children and breastfeeding, all those are positive things to lower your risk for ovarian cancer. Next slide. What are the clinical manifestations? Again, it's really vague. Flatulence and mild gastric disturbance in advanced stages. That's when you see the signs. Enlarged abdominal girth, constipation, frequency, nausea and vomiting, and weight loss. Next slide. Again, for treatment, they would do the surgery, hysterectomy, or this is ovarian, so they can remove the tubes and the ovaries. Radiation and chemotherapy can be used as well. Next slide. Hysterectomy. Hysterectomy is the removal of the uterus, including the cervix. TAH-BSO is removal of the uterus, fallopian tubes, and ovaries. Radical hysterectomy is removing the uterus, the fallopian tubes, ovaries, and removal of the pelvic lymph nodes. Vaginal hysterectomy is the uterus is removed through the vagina. Abdominal hysterectomy, abdominal incision is made to perform the procedure. So different ways to do the surgery, the female reproductive surgery. And then you have, next slide, fibrocystic breast condition. So this is hyperplasia and cystic formation in the mammillary glands. Clinical manifestations are cysts are small, they're soft, well differentiated, tender, and freely movable. This is really important because you want to be able to differentiate this type of disorder of the breast from that of cancer, right? They're soft, well differentiated, tender, and freely movable, and it's often bilateral and multiple. Medical management includes eliminating metallocytins and danzozine, and vitamin E is what you could use. Next slide. Mastitis, acute mastitis is an acute bacterial infection of the breast. It's seen a lot in pregnant women. Um, Clinical manifestations are tender, inflamed, and engorged breast. Um, Management is keeping the breast clean, application of warm compresses, soft fitting bra, systemic circulation, antibiotic, and usually the baby mom can be treated while mom continues to breastfeed. Next slide. It's chronic mastitis, fibrosis and cysts in the breast, clinical manifestation still tender, painful, and palpable cysts. Usually it's unilateral. And in terms of treatment, we'll be treating it just like mastitis, acute mastitis. Next slide. Breast cancer. We don't know what causes cancer, like in many other cancers. It's usually adenocarcinoma. Clinical manifestations very different from that of a cystic breast. It's small, solitary, it's irregularly shaped, firm, and it's usually non-tender and non-mobile, so it's fixed, right? You may see changes in your skin color, prickling or dimpling of the tissue, nipple discharge, usually bloody discharge, retraction of the nipple, and there will be axillary tenderness because the lymph node are inflamed. Next slide. So in terms of management for breast cancer, again, we want to find it early, and this is why we do mammogram. This is why we encourage women to do breast self-exam. So it depends on the stage. So the sooner we find it, the better the prognosis. So we can use, it can just simple surgery, lumpectomy, mastectomy, or you can do a radical mastectomy. So they removing the breast, they removing the muscle, sometimes the lymph node. But you can do radiation and chemotherapy as well. Next slide. Now we are going into inflammatory disorder of the male reproductive system, prostatitis. This is an inflammation of the prostate. It's acute or chronic infection of it. It could be caused by sexually transmitted disease in young men, BPH in older people. Clinical manifestations of fever, chills, dysuria, urgency, and frequency of urination, cloudy urine, pineal fullness, low back pain, arthralgia, myalgia, and there will be tenderness, edema, and firmness of the prostate. Next slide. So medical management is antibiotic, digital massage of the prostate, CISPAP, and of course we're going to monitor their intake and output. Next slide. Epididymis is infection of the epididymis. STDs, is usually what you want to rule out in this case. There will be scrotal pain and edema, pyuria, chills and fever, bed rest, elevating the scrotum and cold compresses and giving antibiotic are definitely the treatment protocol for that. Next slide. Phimosis is a precursor, the precursor is too small, right, to allow retraction of the foreskin over the glands. Generally congenital, and it may be due to inflammation or other diseases, right? Clinical manifestation are infection of the foreskin and the glans penis, and occasionally cause obstruction of urine flow, so we got to monitor for that. The medical management is circumcision, and so when you circumcise someone, there are some, this is usually seen in the younger kids, and so we can treat it, and we'll address that in pediatrics. Next slide. All right, for phimosis, this is an edematous condition of the retracted uncircumcised foreskin, preventing a normal return over the glands. So medical management, warm compresses, and also circumcision, because circumcisions allow the foreskin to be removed, right? Next slide. Hydrocele. Hydrocele is accumulated of fluid between the members of the testes, and what you see is that there is an enlargement of the scrotum and pain, and you can trans-eliminate it. If you bring a light close to it, it will trans-eliminate because it's full of water. Hydrocele, accumulates of fluid. So medical management is we try to get rid of the fluid, so aspiration of it, surgical removal, of the testicular sac, bed rest, elevating the scrotum, and cold compresses. Next slide. Varicose is a dilation of the scrotal vein, causing obstruction and malfunction of circulation, right? So you don't want that. Clinical manifestation is engorgement and elongation of the scrotum, pulling sensation, dull and achy pain. So we have to remove the obstruction. Bed rest, elevate the scrotum, and cold compresses. Very similar, right? Next slide. Cancer of the testes, right? We don't know, like other cancers, the exact cause of it. There are some genetic risks. Undescended testicles can be a risk factor. So what happens? Clinical manifestation: enlarged scrotum, feeling of heaviness, firm, painless, and smooth mass. So this is why we teach men between 15 to 35. That's the age that have a higher incidence of testicular cancer, to monitor, to assess their testes every month, to feel for it, making sure that there's no enlarged scrotum, feeling of heaviness, or painless, firm. It is 97% curable if it's found early. So we can do management, inguinal, surgery, chemotherapy, orchiectomy, radiation, and of course teaching them testicular exam. Next slide. Cancer of the penis, very rare, but it happens. You see painless, wart-like growth of all ulceration over the glands. Surgical removal, partial or total amputation of the penis, management, right? Next slide. Genital herpes, they are infectious viral disease, usually acquired sexually. There's type 1 and type 2. Type 1 is the cold sore. Type 2 is genitalia, but they can interchange. Clinical manifestation: there are fluid-filled vesicles, and generally there's tingling sensation. The first eruption is usually more painful, tingling sensation to the site of exposure. Eventually they will rupture and develop shallow, painful ulcers, pain, dysuria, and leukorrhea. Next slide. This is showing you in both sex the herpes simplex virus type 2. Next slide. So what is medical management? It's a viral infection, so we're not going to use antibiotic, right? So there's no cure for it. We're treating the symptoms: acyclovir, sitz bath, local analgesics. Keep the lesion clean and dry, good hand washing, no sexual contact while the lesions are present. Encourage use of condom, and this is really important in a pregnant woman so that we do not pass it on to the unborn child. Next slide. Syphilis, it is a transmission that occurs from a organism that can occur during sex. It has an incubation period, and usually there are no symptoms. There are stages that the patient will experience, and it's really important because one of the stages looks like, oh, nothing is wrong, and it really becomes a significant problem. Primary stage is where you have this ulceration, this chancellor sore, that also they have headaches and enlarged lymph nodes. So they see this lesion, and then that goes away, and then you go into the secondary stage where, next slide, secondary stage where you have rash on the palms of the hands and sole of the feet, generalized enlargement of the lymph nodes, right? And then it goes into the latent stage where there's no symptoms. Okay, so the rash goes away, so now you go into the latent state, no symptoms, but the disease continues to be destructive to other system, the heart, the nervous system, to the point where you see like psychosis, right? Psychosis. And it's very simple because we just have to make sure we do blood work such as VDRL. to see, and the syphilis RPR, to see if they're positive, because it's treatable with very simple medicine. Next slide. So the management is penicillin, right? Tetracycline or erythromycin if the patient is allergic to penicillin. It can be treated at any stage that you found it, but the difference is the damages that occur from that latent stage cannot be reversed, and we have to treat all sexual partners. Okay, next slide. So we are talking about sexually transmitted disease now. However, the most common sexually transmitted disease in the United States are gonorrhea, syphilis, genital herpes, chlamydia, and HPV, right? And HPV. So gonorrhea again, as I mentioned earlier, HPV is like, we have a whole bunch of them. There's a vaccine for HPV. That's good, to protect. It's usually given between 9 and 26 years of age. Generally, the highest incidence of sexually transmitted disease are in adolescents and young adults, right? You also see issues with sexual abuse. So our key is to really educate, to try to prevent. So that's a primary type of prevention, because you're teaching to stop the behavior from, contracting the disease. So the best way to stop the spread of sexually transmitted diseases is abstinence, right? Abstinence is the best way. If that's not possible, then a condom. Condom used properly is another way. Of course, there's a Healthy People 2020, the goal that has been set, and the goal is to promote the health, sexual behavior, strengthen the community capacity, and increase the access to quality service to prevent sexually transmitted diseases and their complications. So this is really significant, because what you see, there are factors that usually contribute to the spread of STDs. The fact that some of the diseases are asymptomatic, so they don't know that they have the disease, and you just continue to spread it. The gender disparities, the age disparities, the lag of time, that someone is infected, and the complication, and of course social, economical, and behavior factors. Some of those behavior factors are IV drug users, substance abusers, those who have a really high risk sexual activity, those who start having sex younger than usual, inner city resident, individuals that have poor hygiene and poor nutrition, and so forth. There are some complications. All of these diseases that we're talking about, it's going to lead to some type of complications, such as sterility, neurologic damage, ophthalmic infection of the newborn, cancer, and death. So this is really, really serious for us to discuss. All right. So gonorrhea is a sexually transmitted disease that is caused by gonorrhea. It's transmitted sexually, and again, the manifestations are urinary frequency and pain, yellowish discharge, and nausea and vomiting. Next slide. So for male, what you see is the urethra, there's discomfort, there's dysuria, there's yellow discharge, red and swollen meatus. Rectal, for those who engage in sexual rectal sex, you see peritoneal discomfort, purulent and rectal discharge. For oral sex, you see pharyngitis, so there's sore throat and swallowing difficulty, edema of the throat. Next slide. So treatment is pharmacological, because we can do a pap smear, and then we can do a cervical assessment, collect, and do a culture. Remember the swab, and then we treat with antibiotics, penicillin, doxycycline, tetracycline, and remember the teaching about tetracycline and the stain of the teeth. Making sure that they take the full dose, right? And we have to treat all the patient, and hopefully teach them to make sure that they prevent a new onset of gonorrhea. Next slide. Trichomonas is another sexually transmitted disease. Vaginalis tropozone is the organism. Usually, again, it's a sexually transmitted disease, and again, most people are most asymptomatic. The male, urethritis, dysuria, urinary frequency, pruritus, and purulent exudate. Next slide. For the female, you see frosty, like, gray, greenish, yellow, malodorous discharge, pruritus, edema, tenderness of the vagina, dysuria, urinary frequency, and spotting. Next slide. Again, you got to treat with flagyl. Flagyl, there's definitely a nursing teaching for this drug. It gives an anti-abuse type of effect, so you got to teach them the metallic taste, right? And it's a sexually transmitted disease, so we have to treat all the partners, and this is reportable. Next slide. Candidiasis. Candidiasis, this is sexually transmitted disease. Usually you see it could be in the mouth, white patches in the nails. It could be vaginal, so cheesy, tenacious, white cheesy, very pruritus, inflammation of the vagina, purulent, exudate for the male, and then of course if it's systemic, there's chills, fever, and generalized malaise. Next slide. The treatment is, antifungal, so nystatin and topical, and, amphotericin can be used as well. And amphotericin, when the drug that is used, you got to be very cautious about that because it causes, especially for the oral and IV drug, it causes some very uncomfortable symptoms, and they have to be pre-treated for that with Tylenol. Next slide. Chlamydia, another sexually transmitted disease by Chlamydia trachomatis. It is usually, again, asymptomatic. Male show a little differently, scanty white or clear exudate, burning, urinary frequency, mild dysuria. Next slide. The female, vaginal pruritus or burning, dull pelvic pain, low-grade fever, vaginal discharge, and irregular bleeding. Again, we got to treat with antibiotic, tetracycline, doxycycline, zithromax. Again, treat all partners involved. Next slide. So there are the nursing diagnoses pertaining to this topic include anxiety, body image disturbance, coping ineffective, fear, fluid volume deficit, health maintenance ineffective, infection, risk for, knowledge deficit, pain, acute and chronic, self-esteem, situational low, sexual dysfunction, skin integrity, impaired tissue perfusion, urinary elimination impaired. Next slide. So sex hormones, right? Production influenced by the anterior pituitary. Male is testosterone and androgens, female estrogen and progesterone. Next slide. Androgens develop secondary characteristics, really important in tissue building. They are used for indication that shows that there's lower functioning, such as male androgen deficiency or hypogonadism. Adverse effect that we have to monitor for, edema due to sodium retention, acne, so it creates unpleasant adverse effect that will lead to body image disturbances. Next slide. The drugs, androgens, when you're giving them, you got to make sure you pay attention to the drug interaction because it increases the effect of anticoagulants and antibiotics. It decreases the effect of barbiturates. If you use with steroids, can increase edema and the nursing implication for that. Next slide. So we got to teach about the administration, responsiveness, diets, and symptoms to report, and administration consideration. Next slide. So female sex hormones are estrogen and progestin. Next slide. And the uses are for hormone replacement therapy, for those who are menopausal, other, issues where the ovary has failed, infertility work, and palliative breast cancer. And the adverse effect are, make sure you review this, be ready to discuss. Next slide. Progestin is another drugs, and progestin is usually used in combination with progesterone with estrogen to use as birth control contraceptive. All right. Next slide. There are some oral contraceptives. So you have estrogen and progesterone as a combined, right? So it prevents ovulation. So it's used as contraception, and some of the adverse reaction is estrogen excess, progesterone excess. So all those different hormones, you're gonna see complication of when it's too much. And so some of the contraindication to taking oral contraception is a woman that is older than 35, smokers, individuals that have DVT. So other contraindications are thrombophlebitis, thromboembolic disorders, someone who has cardiovascular disease, cerebral vascular disease, hypertension, those who have diabetes, those who have estrogen-dependent cancer or breast cancer or benign or malignant liver tumor or bladder condition. All right, so it's also contraindicated in people that have impaired liver, those who suspect to have, of course, pregnancy, those who are heavy cigarette smokers, high cholesterol levels, those who have obesity, right? There's other ways to also prevent pregnancy, not just through the female drugs, but they are, instead of oral drugs, they also have hormone injection, right? Implants, they have patches, they have the ring, they have post, they call it the B method after pregnancy and taking, a prescribed high dose of estrogen and progesterone level drugs. There's abstinence, there's sterilization, so tubal ligation and vasectomy. There's other intrauterine devices, IUD, that can be used. Of course, we talked about the barrier methods, chemical barriers. So there's a female condom and the male condom. And of course, you have the natural family planning method, especially if Catholic individual. So using the withdrawal method, assessing the mucus level during ovulation. And for male contraception, there's a lot of investigative use of drug, but them for sterilization and condom is the most commonly used birth controls. They are trying to come up with things such as hormonal implants and injections, so it's under an experimental, so forth. So that ends our lecture for reproductive issues. Thank you.